afternoon, depending on where you're joining us from. I do see that the participant list is slowly climbing, so we'll give people a couple of minutes here to join, and then we'll get started. Okay, I see our participant list is kind of slowly starting to people are just joining in their own time. So we'll go ahead and get started here, and we'll get to the meat of our presentation, which is our research team talking about their really exciting and important research. Good morning or good afternoon. Thank you again for joining for our Research in Progress webinar series. My name is Carrington Lott. I'm the Deputy Director at Systems for Action. We are located at the Colorado School of Public Health at the CU Anschutz Medical Campus in Aurora, Colorado. If you're not familiar with Systems for Action, we are a national program office of the Robert Wood Johnson Foundation. And since 2015, we funded research projects all across the United States that focus on testing alignment strategies across the medical, public health, and social service sectors. Today, you'll be hearing from a research team at Case Western Reserve University and their partners at the Greater Cleveland Food Bank and Better Health Partnership. They'll be talking about their research project, which is focused on sustainable service delivery model for addressing food insecurity and social needs of low-income pregnant individuals. And this is a research team that was funded from our 2022 funding opportunity. So last year, they got started February of this year, and this is their first time presenting in our Research in Progress webinar series. You're joining at the very beginning, and you're going to get to hear about the important research that led to this research project, and then get to hear about what they're going to be doing over the next 3 years that we have them in their Systems for Action research grant. So you can follow along on their progress as they continue over these next couple of years. So with that, let's see, can we go to the next slide? I just tried to control it myself, Elaine. I forgot that you were controlling it. Thank you so much. A couple of housekeeping items. You can see here our agenda. We have our welcome. So I'm welcoming you to our Research in Progress series, and I'll hand it over to our presenters so they can talk about their research project. And then we have Christine Lattimore, who will be providing some commentary on the importance of this research. And she's really tapped into the community and can speak from the community side of how this research project is impacting their community. And then we'll reserve the last 10, 15-ish minutes for questions and answers. If you have any questions at any point today throughout the research presentation, please make sure that you find the Q&A box at the bottom of your Zoom screen, enter your question in, and we'll make sure that we get to that at the end of today's presentation. It is the case that sometimes we have more questions than we have time for, and if that is the case today, we will make sure that we get the questions we don't have time to address during the presentation to the research team, and we can try to address those after today's presentation. And then last thing for housekeeping is that this is a recorded session, and we will email out the recording as well as a PDF of the research slides after today's presentation. Next slide, please. So I'll do just a really brief introduction to our investigators. We'll be hearing from Dr. Elaine Borowski first, who is located at the Case Western Reserve University. And we also have Dr. Meredith Goodwin, who is from the Case Western Reserve University. We'll also be hearing from Dr. Alyssa Glenn, who is at the Greater Cleveland Food Bank, and another research partner who is not here today, but is a very integral part to their research team, is Dr. Christopher Mundorf from Better Health Partnership. And I imagine he will probably join for other Research in Progress webinar series in the future. So you will probably have a chance to hear from him at that point. And I know that this is not everyone on their research team. And I think Dr. Borowski can speak to that because they have such a huge, wonderful, and collaborative team. But with that, I'm going to go ahead and hand it over to you, Dr. Borowski, and you can get started with your presentation. Thank you for joining today.
Well, thank you, Carrington and Sadia. Thank you both. This is we're very excited to be here, or I guess it's morning or afternoon to everybody. We're going to introduce you to this project, which is called Nourishing Beginnings, which is this collaborative, as Carrington mentioned, between the Case Western Reserve School of Medicine, the Greater Cleveland Food Bank, and the Community Pathways Hub, which is part of Better Health Partnership. And as Karen mentioned, we are a very large team. And so we really want to acknowledge that, this is a grant about systems alignment. It's about really how to make systems align in a way to produce better health outcomes and reduce health disparities. And so we need in order for this to be successful, you really need a lot of organizations that are really willing to work together, face and solve really hard challenges, and have a shared vision. And we all feel very fortunate that we have this here in Cleveland through this Nourishing Beginnings program. But in addition to our wonderful teams at our institutions, we have to acknowledge the real engine that drives this project, which is our community health workers. You're going to hear more about them, where they come from, the role they play in this project. But it is the community health workers that really establish and nurture the valuable relationship with the pregnant clients in this project. And we believe it really is the magic sauce in the program. So, but really none of this would have happened at all if it hadn't been for the incredible funders who believed in us when we started with this idea over 2 years ago now. And we are extremely grateful to Robert Wood Johnson Foundation for providing us this opportunity to now rigorously study this program and hopefully disseminate it across the state in the future. So I'm going to start us off. Just quickly, we're going to introduce the partnership and in our history. I'm going to pass it off to Alyssa. We'll talk a little bit more about the history of it, and we'll get into the program description, tell you a little bit about our aims for Robert Wood Johnson, and then give you the current status of where we are right now. So Alyssa, I'll hand it over to you.
Thanks, Elaine. Hi, everybody. My name is Alyssa Glenn. I am the Director of Community Health, Nutrition, and Measurement at the Greater Cleveland Food Bank. So just to start by telling you a little bit about our food bank. We are 1 in 12 food banks in the state of Ohio. We work together to cover every county across the state. So we serve 6 counties. And over the course of a year, we serve somewhere between 300 and 400,000 individual people through a variety of different types of programs. And just to give you an order of magnitude, all of those people and the food that they access, it adds up to about 50 million pounds of food over the course of a year. So we're a pretty large scale production organization. We get our food sources from a variety of different partners. We access quite a lot of food from government partners across federal sources, as well as sources in the state of Ohio. We, of course, receive a lot of food through donations, both those individual donations that you might be familiar with, food drives that take place across the course of the year, but also larger donations through food vendors, such as big grocery stores or organizations like Orlando, which is a big bread company. To fill in the gap, we purchase a lot of food as well. So we frequently try to focus those purchased items on more nutritious foods that we might not be getting through other sources, like high quality proteins, for example, or whole grains. And then there is definitely a strategic focus on improving the quality of our food. And just to speak to that, of that 50 million pounds of food, about 18 million is produce and 9 million would be perishable, high nutrient value products, such as proteins or high quality dairy items, for example. Over the last 5 years, we've done a lot of work to build out our Food is Medicine initiatives. So these are programs and initiatives geared towards improving health outcomes directly. So these are mostly partnerships with healthcare. The kind of bucket of initiatives we have here, we have Food is Medicine clinics. These are food prescription programs where patients are screened as food insecure and then referred to nutrient-dense pantries to access their food prescription. We have mobile produce distributions, food insecurity screen and refer programs, quite a lot of nutrition education. And then Nourishing Beginnings is really our first foray into food intervention research, which is very exciting. And then just a note about what's happening across the country. As policy incentives shift towards embracing more social determinant of health work, food banks are coming along to try to address those needs. So there's quite a lot happening across the country to try to improve the health of the people that we serve. Next slide, please. Okay, so this is probably information that everybody is very familiar with. Food insecurity is associated with poor health outcomes, especially chronic disease. If you are food insecure, you're more likely to develop heart disease and diabetes. and it's more difficult to manage that disease. There's also a significant relationship between food insecurity and stress and depression. And in Cuyahoga County in particular, we have a very disparate rate of maternal and birth health outcomes. So Black babies are 4 times more likely to die than white babies in the first year. Next slide, please. So this program in particular was born out of some COVID-specific developments that happened. So early on in COVID, there was additional funding that food banks received, and a coalition to address infant mortality in Cleveland suggested that there was a significant population of people, high-risk pregnant people, who needed food. So we were able to get food to this population due to some of that additional funding we had for COVID. Now, we knew that the program was very well received, but we really wanted to study it more deeply in order to hopefully achieve sustainable funding for the population that we're serving. Next slide, please. And because in Chris's absence, I'm going to do my best to introduce the Community Pathways Hub. So the hub is what's called a care coordination model. This is really an interesting model that's expanding across the country if you're not familiar. And there are about 10 in the state of Ohio. But what community care coordination models do is they leverage community health workers to form a connection between healthcare and social care. And there is in Ohio a pathway for reimbursement through Medicaid. So it's a unique opportunity to work with hubs because there is reimbursement for these social care connections and also reimbursement specifically for community health workers that can be employed through a variety of different types of organizations. So this is why we are partnering with the hub, in part because it gives us that connection to community health workers in a likely sustainable fashion.
All right, so I'm going to pick us up and now introduce a little bit more about the program itself. Okay, so this has been almost now 2 years of a process that began with our 3 partnerships. And the goal was, as Alyssa mentioned, really was to try to create a sustainable program that had rigorous measurement underneath it, so that we could study this impact of a direct food intervention with CHWs on health outcomes. So it was about an 18-month process to develop it. We originally, the 3 partners co-developed the shell of the program, and then we brought community health workers to the table to really look at the recruitment, delivery, and we continue to really navigate the process with the CHWs at our side because they are the boots on the ground, knowing both the barriers and how in which to make this most successful. The aim of the program is to address the negative effects of food insecurity on pregnancy. But this is mainly through this integration and streamlining of a referral and a food delivery system to speed that process up and to increase access to healthy food. But it also being facilitated by the community health worker, as I mentioned, who also provides support for other unmet social needs. Ultimately, our goal is to improve both maternal and baby health outcomes, which we hope that it will in turn reduce healthcare costs so that then managed care organizations through Medicaid and others would then potentially provide a reimbursable pathway for this direct food access in the future. So our RWJ study grant aims are 3. First is to do just what I said. We are in the process of conducting a rigorous examination of Nourishing Beginnings using 2 alternative food interventions that you'll hear a lot about more in a minute, looking at intervention targets and these long-term outcomes. And then simultaneously, this is an implementation study as well at the same time where we are doing constant quality improvement analysis of our project indicators. And lastly, in the latter part of our cycle, we hope to expand Nourishing Beginnings to other kinds of health referral or home visit referral systems that don't necessarily utilize the Medicaid funded support pathway, as well as trying to develop a toolkit and things like that that would allow us to expand the program across. We have a very rich network of hubs and food banks across the state of Ohio. And so our method for this particular study is that we are enrolling 160 pregnant individuals who have been referred to the hub, and they are referred from a number of different organizations. They have to be 18 years or older, pregnant and less than 22 weeks gestation, English speaking for the most part, to fill out, to complete surveys. The participating CHWs are from grassroots community organizations and health providers. And then you'll see there are 2 intervention arms and a control group that comes from MCO data and historical data. Just briefly, this is our method of randomization. You can see that our population are Medicaid-eligible pregnant individuals. They have to be enrolled in the hub. Once they're enrolled, they are then enrolled into Nourishing Beginnings and then randomly assigned to one of these 2 intervention arms. And this is our control group. I'm not going to spend too much time on this, but when you see the slides, you understand that this is sort of our bigger picture of understanding what we believe will happen. And what we hypothesize that will happen is, the first is the impact, obviously, of these interventions on the maternal and child outcomes. But we're also very interested in better understanding the mechanisms and how food delivery and food access might impact these other factors that are also directly related to prematurity and other health outcomes. We could spend a lot of time on this, but feel free if you have any questions to ask later. All right, so I'm going to hand it back to Lisa, and we're going to talk about our intervention arms.
Thank you. Okay, so we're going to jump into the intervention arms. And if we go to the next slide, as a reminder, there are 2. We're testing food delivery as well as cash assistance. But that said, from early conversations with community health workers, we heard that cooking tools are a challenge for the population that we're serving here. So it was likely that people wouldn't have tools in their kitchen to cook the foods that we would be delivering. So understanding that that would be a problem, we developed a cooking tool assessment that's given to both intervention arms. We anticipated a $100 budget for every participant. That said, we have gone over that budget for most of the participants on the project. As we know, inflation is a significant concern at this point in time, but also the people are needing quite a large number of different items. So this is a picture of what that cooking assessment looks like. In general, the cooking assessment is completed in collaboration with the community health worker. So you can see the variety of items that people can select, indicating what they need, as well as some rough estimates on how much those items cost, so that people can prioritize what items are most important to them. And then moving on to the first intervention arm, which is food delivery. When thinking through why this particular intervention may be helpful for individuals, we were thinking that by providing food that's home delivered, it's likely to reduce the stress of shopping and food selection that so many people have. I mean, you can even think about in your own life, whether you feel any type of stress around shopping for foods. It's a lot of work, especially if you have, kids or you're pregnant and you're working and you're tired. So by home delivering, we're hoping to eliminate that stress that people feel just in being overwhelmed with where to get food and what foods to choose. And of course, by providing nutritious food, we're hoping to improve the nutrition level of the foods that people are actually consuming. And then in addition, providing some nutrition tips and some recipes, hoping to increase that self-efficacy for consuming nutritious food. So the actual food delivered, we have 1 week's worth of food home delivered every other week based on preferences and family size. So a family that has 4 people will get twice as much food as a family that has 2 people. And we do have a process where we're asking people what types of food preferences do they have? Do they have allergies? Do they have cultural norms that we should be looking to meet? Do they have particular items that they especially like or don't like? We are taking all of that into account when we pack the food boxes. So in addition to the 1 week's worth of food every other week, we do have recipes and pregnancy-specific nutrition tips that correspond. So you may have, for example, some canned salmon in the box and a nutrition tip about the benefit of omega-3s to a healthy pregnancy. In addition to these things, we do a pantry staples box every 3 months. So the contents may include always a healthy oil, such as olive oil, spices, vinegar, so you can make your salad dressings, and some other pantry staples. And then the nutrition education tips I mentioned. We wanted to build in an ability to get regular feedback from participants. So we do send a text survey approximately 1 week after their food delivery. So after every delivery, there is a text that's sent out to say, how satisfied were you with your food box? Is there anything that you didn't like, that you especially like and you want to see again, or anything else that we should know? Next slide, please. So to give you an example of what we send, this is a sample box of contents for a family of 4. So we use a grid that is built off of the recommendations in the Thrifty Meal Plan offered by the USDA. So we have our different food categories: vegetables, fruits, proteins, dairy, and starch. And we look to have this number of pantry items for each of those categories. And furthermore, we look to split those approximately 50-50 between perishable and shelf stable. And that is also based on some of the feedback that we got from community health workers early in the exploration process. People have limited space, both in shelving, but also refrigerated and freezer space. So we're trying to really split that up so that people have both. And then these are some example recipes that we include. A couple of pictures of the boxes here. So this actually equates to at least 2 boxes. There's usually a shelf-stable box, a perishable box, and then a few frozen items. And here's an example of a recipe that we include. We also do, as I mentioned, a lot of cooking demonstrations and nutrition education at the food bank. So this is a recipe that has been vetted in the community and done at cooking, or rather at produce distributions. And we've gotten very positive feedback on it.
Okay, this is me. I'm going to tell you about the second intervention arm. So remember, originally the project was born to do home food delivery to pregnant women. But in order to see what that impact was, we needed to compare it to something. So when we were setting out to design this control group, it was quickly apparent that not giving an intervention was not acceptable. So these were women with a lot of needs that were pregnant. So not giving them additional support and additional resources was not going to be a viable option for our community partners. So we had to come up with something that was fairly comparable and maybe acted on similar mechanisms to impact our intervention targets. So we developed this second arm to be cash assistance and paired with healthy food navigation. So the goal of this was really to provide additional financial support so that individuals could purchase on their own healthy foods during their pregnancy. Couple this with navigation, it would help reduce the stress of them finding healthy food options near them. And ultimately, the goal, of course, is to improve their nutrition and their self-efficacy around eating healthy during their pregnancy. I will say that with the food cash assistance, there's no stipulation to the participants that they have to spend their money on food. We do not check it. We do encourage it and talk with them about it, but they are able to spend it however they want. So if spending that cash assistance on paying a bill helps to reduce their stress, then that's definitely something they can and might choose to do. So as part of this intervention, every other week we provide our participants with $30 deposited directly into their personal Cash App account. And we could spend a lot of time talking about how we came to use Cash App. It was a lot of negotiating with the university and talking to our community health workers, but most women already had Cash App and were familiar with using it. If a client doesn't have a Cash App account, we work with them to create one, which also is a reimbursable pathway for the community health worker. And if for some reason they can't have Cash App, we have other alternatives in place. But for the most part, thus far, it's been very, very successful. So we give them $30 every other week, and then this navigational support, which I'll talk a little bit more about in a second. In lieu of the recipe tips that go to the food delivery group, we give individuals in this intervention arm a cookbook at the beginning of their time with us. And that cookbook has easy to follow recipes that are made with few ingredients and are healthy for pregnant women. The clients also get the $100 in the cooking supplies. And we are just beginning to roll out providing those same nutrition education tips that are going to the food delivery, home food delivery clients to our cash assistance clients. So that is equitable between the groups as well. And finally, similar to the first intervention, which Alyssa described, we were interested in getting regular feedback from these clients about their satisfaction and their utilization of this support for their intervention arm. So we are also doing the survey the survey every other week to them. And we ask them, like, how do they spend their money? Did they make any of the recipes, things like that? Okay, so moving on to talk about can I say one more thing, Elaine, back up really fast. So just to tell you, the $30, we identified $30 as the amount really out of default because of federal tax guidelines and tax restrictions. So you cannot get more than $600 from participating in a research study in a calendar year before it has to report it as income. So if we were to give them more than $600 through this program, we also, we're not going to talk about this really, but we are providing some incentives for filling out data collection things. So all in combined, they have to get less than $600. So that's how we wound up with 30. We know it's not comparable to the amount of food that they're getting and the cost of the food, but that's kind of where we are. And that's one of the limitations of of that. Okay, moving on, talking about Fresh Finder. So Fresh Finder is what we're using. It's the tool we're using to do the healthy food navigation. And it's really integral to this arm, because it helps our clients. Most people know what's around them, but they might not think about certain stores as options for places they can access healthy food. So we have a lot of information about this on our website, so I'm not going to go into detail. You can visit prchn.org, which is the Prevention Research Center where we come from. Our website, it's on there. You can also Google Fresh Finder, and there's information. You can also reach out to one of us and we'd be happy to tell you more about it. But basically, it's an interactive map built on data that is collected annually. We send interns out into the field every summer, and they go into every single food retail location in the city of Cleveland and do an audit and list the kinds of things that are available in the store. Then that is used to population this map, thanks Elaine, that any health professional really can use with their client. They use the map by typing in the client's address. There's a little bar there where Elaine's showing, and they can search their parameters, what they're looking for. Say, I want, my client doesn't have a car. I want things they can walk to. So maybe within a half mile of where they live, they plop it in there, and up pops all of the food retail locations within them. You can click on any one of these stores and it'll show you basically the categorization of the store and what's in there. So does the store carry whole grain options? Do they carry a lot of fresh fruit? How many types of fresh fruit do they carry? Does it accept SNAP and WIC? The numbers are open for, or the hours and stuff for the store are open. Also on this map, you can find bus and transit. So someone could sit with their client and say, well, let me show you how to get just a little farther away, maybe using your, the bus routes or whatever. So that's Fresh Finder. We train our community health workers how to use it, and they sit down at least one time with their client at the beginning and talk about their food environment and where they can do it.
Sorry, I'm really speeding you up, Meredith.
Sorry, I can talk forever. So thank you for nudging me a lot. I'll try to be quick talking about all of the data, because that's at the heart of that, and that's kind of my background. So you'll see the model that Elaine showed with you a few minutes ago. We have all those outcomes we're interested in, and a lot of mediators and potential moderators for how those are impacting outcomes. So to do that, we have a whole host of data sources we're relying on. And the first one on this list is probably one of the most significant ones. That is the data that's coming from the Pathways Hub. So that provides us with like the participant demographics. That's where the community health workers log their encounters with clients. So all of their data that the community health workers collect is in there. And that's where the majority of the maternal and health outcomes are available there too. Those outcomes, it's really important to note, are verified by the managed care organizations. So that's a really good, clean source of those outcomes because they have that as part of their normal process anyway for their billing process. So again, that's one of our biggest sources of data for this. The next major source we're going to talk about is what we collect directly from our participants, and we call this the parent survey. We do it at baseline when they enroll, about 8 weeks later after they've started receiving their intervention, and then near the time they're projected to deliver, so around 36 to 38 weeks. If they deliver early, unfortunately, we get it as close after they've delivered as possible. And so what this survey is it's a collection of validated instruments, and it covers a variety of domains. You see them on the slides: food insecurity, depression, stress, social support, things like that. We measure their shopping and eating patterns, their beliefs about eating healthy, all of that's on the parent survey. We worked really hard with our community health workers to keep this list as manageable as possible of all the things we measure, and to keep it really concise. It's done electronically. We gave clients the option to do it themselves or to have their community health worker read it to them. Most have opted for their community health worker to read it to them. We just ask that it's done the same way every point in time, and clients are reimbursed for their time. Moving along, the diet recall is what we're using to look at the nutritional consumption by our clients. And we are using the NDSR for that, which is a 24-hour diet recall. So at every point in time, we do it, which is twice, baseline and near delivery. We're doing 2 phone calls, 2 24-hour recalls, 1 from weekday, 1 from weekend. Those are averaged together to give us an average of the consumption during that period of time. And last thing on this list was the participant satisfaction utilization. Alyssa and I both talked about that briefly. And one more thing, when we do the NDSRs, we do collect a little satisfaction with the community health worker themselves. So the client tells the person doing their diet recall, the person who's on their phone with them, they ask the client about the client satisfaction with the community health worker and what that relationship is like. So that's collected by somebody else outside. Okay, thank you. Moving on. So really briefly, I want to give you just an update as to where we are. We started this very first client the end of July of last summer, very beginning of August, and we really intentionally moved slowly. We only took 1 client all the way through getting their intervention up and running to make sure our systems were working and everything was going well. And then we rolled out very, very slowly. We're a little slower now, maybe than we'd hoped to be, but at the beginning we wanted to go slowly. So we did that. We currently have 20 clients receiving the intervention. 2 are currently 22 that are enrolled, 20 are randomized, 2 are still pending the randomization because they're getting their baseline data collected. Of those 20, 11 are in the food box and 9 are in the cash assistance arm. 15 are still active getting the intervention. We have had 2 that are done and have graduated on. We have 3 that we've lost to follow up. In this group, we have also had 9 babies born. From a community health workers perspective, we are actively working with 4 different agencies, and we are in talks to engage 1 additional agency coming on soon, hopefully. We have 4 community health workers representing those agencies that are actively seeing Nourishing Beginnings clients. We have lost 4 since we've started. We also have 2 more that are in the process of being trained. One's done with their training, but has yet to take on a client, is just about to do that. So you'll see, Elaine's going to talk to you a little bit more about this, but the changeover in community health workers that we're engaged with has been something that we are working through. So go ahead. Thank you.
Okay. Thanks, Meredith. And thanks, Alyssa, too. All right, so now we're going to move on to a little bit of the challenges that we've experienced so far to date. I think, as Meredith mentions, probably our biggest challenge has been just the slow enrollment, but us really digging in through our various QI processes to really look at what the issues are. And the largest one has been this idea of the CHWs, who really are this secret sauce, is that if that group close, and if there's a high turnover, then there's a slower retraining. And so we're learning, okay, if this rolls out long term or larger, how do you not lose people in the process of that? I think another major part of the enrollment was we thought we would have far more referrals. We do have a lot of referrals coming in, but they are coming in much later in the gestational stage than we had hoped. And so that's another QI right now of looking at, why are they coming in their 25th, 28th week? The last one I think is probably it happened initially, but there were participants at the beginning that really wanted one arm or the other. And I think that's probably not unusual in any randomized trial, right? Because in the consent, they know both arms, and then, not wanting to, but I think we've not had anybody drop out because of the group they've been assigned to. Initially, the burden of consent and data collection really was a challenge. But I think that we have been, I'll talk about it in a minute, we've been very lucky that we worked with our IRB. For those of you out there in this situation, this, getting a medical school oriented IRB to understand that, a 19-page IRB reading is not tolerable. We'll talk about it in a minute, but it's really changed quite a bit. And I would say just this internal communication with the CHWs, because they're on the ground, right? But you can see this very sort of complicated infrastructure. So using our communication and trying to understand the best way to communicate has been the best. I will say, though, that none of this would be possible, again, without this additional funding that we just received, both through RWJ, but also I would say through CareSource, which is one of our largest managed care organizations, who gave us funding to specifically address the CHW capacity. So we have funds to actually work specifically with the community-based organizations to figure out what is the best way to help them, build capacity in the CHWs in order to continue to build capacity in this program. I don't know, Meredith or Alyssa, anything else to add? You think that's strong enough for now? Okay. So going back to the aims for RWJ, the second one, as we mentioned, was the quality improvement. And if Chris Mundorf was here, he would be doing this, but we'll again try to do it for him, is that we have a built-in implementation structure to the project. And we have monthly QI meetings that Chris leads. And it's basically a very structured way in which to take a problem, put it through a process of different approaches. You put them into you basically do a plan, do, study, right? You put it into the do phase, and then you study what it is. And so one of the things was increasing the CHW capacity. So we knew we needed to train more CHWs, do it more quickly, engage more and more intensely with the organizations, and really engaging with the organizational leaders to identify what the barriers were to participation. A second one was, again, with the delayed enrollment. We just continue to streamline this internal recruitment and tracking procedure, which is sort of the heart of the systems alignment, hoping if we can get it to a point where it is something transferable to other groups. And then I just mentioned with the consent, with our university's IRB, it was greatly reduced. Initially, when it was being read to them, it was about a 2-hour process, which has now been greatly reduced. And actually, you'll meet Christina in a moment, but Christine helped us develop actually a video now that provides an overview of the consent process that will provide even another option for reading the consent. The third aim has to do with the expansion of the program. I'm not going to spend too much time on this research in progress, but you will hear more in the future. But this idea of us really starting to think about how would this expand out to different groups. We have other referral resources, particularly ones that come through the public health system that we would like to integrate. One of them, which is called Moms First. And the other thing is to really think about how would we try to disseminate this out to the other food banks and the community pathway hubs across the state. I think the last thing has been an expansion for us is understanding that we might need to develop some additional training for the CHWs that are specific to pregnancy nutrition. And so, that was a quick one. So thank you all. We're going to turn it over for questions. And I think that Carrington, are you going to go first, or I think we're going to move to Christine?
I think let's move to Christine first, and then we'll save the last amount of time for some questions. So Christine, do you want to?
Well, let me first just introduce Christine again, if you don't mind.
Sure.
So Christine is really, like I think Carrington mentioned, is truly been our superhero CHW, not just in the work that she does on the ground, but you all know that community-based research, it's all about the relationship and the engagement and people really speaking their mind and being authentically engaged. And we are so grateful to Christine and all the CHWs, but for really being a part of the process with us, right? And leading where we need to go with this. So without further ado, Christine, thank you. Christine is with United Way CHWs, and we'll let you go from here. But thank you for being here, Christine.
Good afternoon, everyone. My name is Christine Lattimore. I am a supervisor in CHW. I do work for United Way at Greater Cleveland. In conjunction with Case Western Reserve and their program, I do thank you for the opportunity for first off allowing me to be here to speak. And then also, I do work with one of the care coordination models, which actually goes through one of the hospitals here in Cleveland. One of our main hospitals is called MetroHealth Hospital. So I go through them and we call them the hub. I work with mothers with unmet social needs. And I just want to let you know that this program is actually really great, gives mothers and actually families in general the opportunity to see what is going on in their community and what they have access to outside of their community. So it's saying that the program came along maybe about, what was it? I think you said last July or whatnot. And I remember bringing on actually the first client, and it was very interesting to see how the program would go. The mom was very open to it. She literally she was pregnant with a child, and she was maybe a couple of months into having her child. So she had a 4-month-old, and then she was pregnant again, and she was very confused. She was upset, and the hub literally took this mom in. Nourishing Beginnings helped mom with everything. As they said, that we went through the whole model and explained to her what it was, and that actually helped us as CHWs and myself to see how we can make it better. So saying from that, we discussed about the different interviews and the different partnerships and what worked and what didn't work, and some of the barriers for the clients that we saw and understood were the food deserts, the physical environment, how stores are not accessible to everyone, the lack of relevant assistive technology such as laptops and maybe even Wi-Fi. That was a very big deal. Even the negative attitudes towards food insecurities in itself. So with the model, seeing how you can look at it online and look at it from your cell phone, you can see where there's a grocery store. Maybe you are not aware, because me, myself, I am not aware of the different stores that are in my community all the time, or different stores that open. So that also opened up for the different, what do we call it? The different food diets and whatnot. So one good thing about this program is they look at your different, maybe religious needs. Maybe if you are a vegetarian or vegan, an omnivore, someone that eats everything, they will make this box completely for you and your family. You can be a mom, first-time mom, no children, and be by yourself. That box will be made for you. And you can have a family of 10 children, and the box is made for you and your entire family. So with saying that as well, the one thing I really appreciate about this program is that we use each other in the different systems in a great way. I'm going to give you a quick story. A mom, actually, she lost her home. She had a fire this past winter. It was just before Christmas. And I actually was on vacation, and we speak and talk very often. And I let the whole system know, Nourishing Beginnings, MetroHealth, the hub, that I was not going to be in. All of the systems, the food bank, Nourishing Beginnings, and the hub all came together, helped mom receive housing. That's something else they didn't talk about, but I will let you know they do help out with that if needed, with the resources that are around. This is not something that is funded through the program, so I do want to be specific about that. But helped with housing, helped her with daycare, made sure that she had everything that she needed. And even she still received her boxes that she received every 2 weeks. And made sure that mom had either, it was like a little box, something that you would take for a picnic or whatnot, and had ice for it. And they continued communication with this mom until the CHW came back. What a great program. What a great system. And I just want to add on to that is mom feels to this day very confident that Ohio, the United States of America, is working for her. And I say that because we have to go through these IRBs and the different programs and whatnot. And this information is relevant. Due to that, this helps with funding for other mothers, for other families. And this can be something that we may use as a model for the rest of our nation. So I only had a few minutes to talk. I wanted to kind of like put everything together.
Nice.
But, I didn't know if you wanted me to add anything else.
No, we'll see, but maybe people might have questions for you though.
Okay.
Yeah. All right, we'll hand it back to Carrington. Thank you, Christine.
Thank you so much for presenting on your research and telling us where you are and kind of where you're headed. And Christine, thank you so much for joining and providing that real boots on the ground kind of experience that you have. And I know you're a person that says yes to everything, and I'm glad that you said yes to providing commentary on this presentation today. So thank you. We have about 15 minutes left for questions and answers. So if you have any questions, please make sure that you locate your Q&A box at the bottom of the Zoom screen and enter in your question. I do see that we've gotten some good questions in so far, and we will do our best to work through these. And if we don't have time for all of them, again, we will make sure to give the unanswered questions to the research team so that we can address those. So with that, I know we've gotten a couple of questions in here just about the program itself. So I think I'll start with those. Let's see if I can kind of bundle some of these up. We had a question about why you're delivering the food boxes every other week instead of weekly. And then if you could maybe talk about just how you actually package the food boxes and deliver them to the participants.
I can start out first, Liz, and then you can mention, I think initially as a pilot, if those of you that don't know the Systems for Action, this particular funding group was that we were to take a pilot, right? This was something we'd been piloting and now really to sort of put it in a programmatic way. So during the pilot, we weren't really sure, right, what the capacity would be like, I think, for the food bank to do this delivery process. So every other week wasn't exactly, unless Alyssa has a different answer. I think it was more from a logistics standpoint, but also I guess we also have to remind ourselves is that we could not have increased the money to them every week, right? Because of this limitation we had. Alyssa, do you want to talk a little bit more and then talk about the boxing of the food?
Yeah, I think there are a lot of considerations, but I know we had a lot of conversations about what the capacity of participants would be to cook the food and to store the food. So, expecting someone to completely change what they're eating by 100%, if we provided 100% of people's nutritional needs, that would be a little unrealistic, to give somebody a whole new variety of foods and expect them to eat all of that, in addition to all the capacity issues. So there was a lot of varied conversation about it. And we landed on, well, let's start at 50%, and then we'll see what the feedback is and go from there. As far as how we pack the food, I don't know if this is helpful at all, but if you remember that grid that I showed that had all of the different categories of food, we actually have like little pack sheets that we have. So based on people's customized feedback as to what types of food they want, their household size, we actually shop the food boxes at our on-site food pantry, which has a broad variety of food. And we, note down exactly what we're including. So again, we're aiming to do, X number of items in all of these different food categories, approximately 50-50, perishable, shelf stable, and then of course, accounting for everybody's personal preferences. So we customize, shop those boxes, pack them at the pantry, label them, and then we deliver them by using volunteers. We do have some delivery programs that don't use volunteers, but we've actually found better success in using a volunteer base to do these deliveries because they really care. They do a good job. And sometimes, getting this box to actually make it into the hands of the individual who's receiving it, sometimes it takes a little bit of work. They might be outside of the house. We've had people who were out of the house to pick up their kid at school or at daycare. And so when you have someone who really cares about delivering that food, they go the extra step, call us, make sure that we know exactly where when the person will be back to pick up the food and make sure that connection is made.
Thank you. Okay, moving on to our next question. There was a question about how you select the families to participate in the program and how long they participate in the program for.
Meredith, you want to take that one?
Sorry, I was muted. Yeah, so our goal is that anyone who is eligible that is referred to one of the community health workers that's participating in study is approached for the study. So we're not really selecting them. So the referrals come through the hub. The hub then shoots them out to different community health workers. Not every community health worker that the hub works with is part of Nourishing Beginnings. So as long as it goes to a Nourishing Beginnings community health worker, they're approaching all of the women about whether or not they'd like to participate. So that's kind of about selection. What was the second part of that, Carrington? Sorry.
That's okay. The second part was about how long they participate in the program for.
So yeah, so they're actively getting their.
Yep.
I think you
Meredith
froze,
just
Meredith.
froze, yeah. 3 minutes, unstable. I'll jump in, yeah. So they're followed, this is a little bit tricky though. They are followed through 6 months post-delivery. But the one tricky part of this that we didn't really talk too much in this is that about 1 month after delivery, those that are in the cash arm typically can no longer, they usually, depending on when the pregnancy occurs, right, is if they reach that point. So we move everybody over to food in the last, at 1 month after the delivery, right? So really that's why our concentrated outcomes are basically baseline to delivery. So I don't know, Meredith, I just kind of explained the 6 month and the crossover at the 1 month post. I don't know what else you were going to bring up. Yeah.
Yeah, I was just going to say that. So we really are engaging with them through 6 months postpartum. Yeah.
Thank you. Our next question is, did you or how do you work with local WIC agencies? And are there any considerations for monthly WIC benefits that folks might receive for developing the two interventions, or thinking about SNAP benefits too?
Yeah,
Yeah, go ahead, Alyssa, because then you're the
Oh,
most contact.
Oh, thanks, Lee. I was about to punt it over to Christine, but Christine is probably the best person to respond to this, but I will share that, the food bank actively has folks connecting people to SNAP and WIC. I believe that's what community health workers are actively involved in also. But consistent feedback is that SNAP is not enough. And WIC in the state of Ohio is really a challenge. You have to go in person every 3 months to a WIC location to load up your card. That's once you're enrolled in the program. And you also have to go in person to enroll. So WIC is underutilized nationally, but the situation in Ohio, I would say, is probably worse than average across the country. And then Christine, if you're still on, I think you have probably very valuable experience in connecting people to those benefits as well.
That's the one thing that the individual, actually, the community has expressed that this program with Nourishing Beginnings has helped them to understand how to use vegetables and fruit. The recipes have really helped. And the one thing with the CHWs do, we sit down and we talk about it. Like what's the nutritious value? And Nourishing Beginnings helps with that. They show all of that. So I know it's kind of getting off what you asked, but I just want to add that in, that the regarding the food stamps, it does not give enough. I mean, even bread is high at this point. So the families are very, very appreciative to see how they can do things. And we also speak about planting. I know that's something at a later date, but how you can use the seeds from something else, or then if you have a watermelon, how you can use maybe your blender to make other things. So I know I'm getting off on something else, but this is something that Nourishing Beginnings actually has, and we have talked about. I know we do not have enough time to go into everything, but they offer so much, and the family is very appreciative. They add this into their income and see how they can stretch things. They are open to fish. They receive fish and other things as well. So they are receiving things that they never would have offered themselves or their families. So I do want to say thank you.
That's good. I think one thing, going just back to the question, is that in general, when somebody comes into the hub, that initial intake is done by the CHW. This is not related to Nourishing Beginnings. This is prior to that, where they are then assessed for their unmet needs. So if they're not signed up for WIC or not signed up for SNAP, that becomes a pathway, right, in which the CHW then works with them to do that. So I think that that's an automatic. Your other question was probably more in the program development piece, but I think, as Alyssa mentioned, one of the difficulties we have, particularly with WIC, is that it really does require clients to really be able to mobilize and get to meetings. And we understand why WIC does that, right? They provide a lot of counseling and that around food. And so in the model, I put it up here just to understand, the best we can do with this is this. If as a researcher, I'd be asking, well, wait a minute, if somebody gets WIC and you added this program, we're going to only be able to control it through as a moderator. So, right. So we'll be able to look at whether or not individuals who received WIC or SNAP, did that alter any of these relationships of the interventions? Not sure that answered the question, but it's kind of multi-layered.
I think you did a great job. Thank you. Let's move on to our next question here. We got so many good ones in. Let's ask this question here about Medicaid reimbursement. So you mentioned that this is reimbursable Medicaid service. This is a very specific question. We'll ask it and then also ask the others. Can you share the CPT code that is used? And then does this then cover just the community health worker expenses, or does it cover other budgetary expenses like the cash or other resources?
So this one's a little bit beyond probably the discussion for Nourishing Beginnings, because it's sort of the given of the program. So in Ohio, we have these hubs that have those relationships established with the managed care organizations being funded through Medicaid, right? And the hub itself establishes contracts with the organizations that employ the CHWs. And so all of that background reimbursement process happens through the hub, which is why that was the reason why the hub kind of came into the program. We mentioned why the two other organizations came in was because the hub had this natural method and reimbursement pathway, at least in the state of Ohio, that if this would work. And we would say too, that in that early stage during COVID, when those foods boxes were being delivered, the First Year Cleveland Coalition went to the managed care organizations and told them about the program. And the program basically said, managed care organization said, we might be interested in making this a reimbursable pathway, the actual food delivery, but you have to have evidence to show us that it basically has some impact. So it's kind of, unless you're in Ohio, it makes it a little bit difficult to explain how you could tap Medicaid. If you're in Ohio, then yes, reaching out to the hub, one of the 12 hubs or so that are in Ohio would be the best way to go. Alyssa, were you going to add to that?
Yeah, I was just going to say the food box itself and the food box delivery are not currently reimbursable.
Exactly.
But what we're hypothesizing and hoping is that with some demonstrated outcomes that we can, include those two services within the pathways model. So we're building off of a model that exists, and that will hopefully lead to the sustainable pathway for reimbursement.
Correct.
Thank you. I think we have time for maybe one or two more questions here. So our next question I'm going to ask is, are you able to share average cost per participant for the food box arm, or maybe average cost per food box?
Yeah, so that's a tough one because there are two ways to answer that question. There's the cost to us and there's the market value. Because we have varied food sources and we receive free food, like quite a lot of free food from federal and state sources, as well as donations, something might not cost us anything, but the market value of that is greater. So if I had to guess, I don't think I've really gone through and costed it out. The market value of the perishable box and the shelf stable box together would probably be on the order of $50 to $60. It would have been a little bit less pre-inflation. The cost to us is going to be maybe 65% of that. And that's one of the benefits of food banks, is that we have, we're actually very high quality, low cost food to us that we can share with the community.
Absolutely. Okay, I think I've got a couple of announcements. I think I'm going to end questions there. If you asked a question, we'll make sure to get this to the research team and we'll follow up with you after today. We do offer a certificate of completion. So after today's presentation is over, that's okay.
Sorry, I forgot
You can
that.
share your screen, that's okay. If not, that's quite all right.
Hang on.
If you would like to answer our survey on today's presentation, that would be great. And at the end, you can notify us if you would like a certificate of completion, and we'll make sure to get that to you in a timely manner. And then also, this is an ongoing research and progress webinar series. We do this every 2 weeks. We have our next presentation. Thank you so much, Elaine.
There we go.
On May 31st from our team at Morehouse University, Research to Understand Systems of Housing, which is an acronym for RUSH, the feasibility and acceptability of aligning systems for fathers. And we'll include a registration link for that in our follow-up email, which will also include a link to the recording from today and the slides. I want to thank the research team and Christine for joining today to provide an update on how their research is going. And again, we'll have this team for the next 2.5 years. So if you want to follow along with their project, please do so. And we look forward to having you join us for future presentations. Thank you again for joining today, and I hope you have a wonderful rest of your day.
Thank you. Thanks for having us.
Thank you.